Per essere felici noi dobbiamo essere noi, cioè dobbiamo essere una rete, dobbiamo essere insieme e dobbiamo essere insieme in modo tale che 1 + 1 faccia 3.
Please welcome Jonathan McKay, Director of Partnerships at PRACALT.org.
Shortly after South Africa's first democratic election in 1994, the country was beset by multiple, although interrelated, health catastrophes. Thanks to the HIV and AIDS crisis, by 2009, the number of women dying in childbirth doubled. At one point, South Africa had the distinction of having the highest maternal mortality rate of any country not at war. I'm incredibly relieved to say that the situation has dramatically improved since then. A new administration at the National Department of Health and new measures that they've instituted have gone some way to reversing the trends in maternal mortality. But for women, conditions are still dire. And to make a difference in their lives, innovative solutions are required. We can't rely on what's been done before. To that end, the National Department of Health began to think about how they might use mobile technologies, the ubiquitous devices that had found their way into the hands of almost every man and woman in the country, to create a national database, a national pregnancy register that they could use to collect information from new and expectant mothers and plan for ways to improve their services. And that's where we came in. I'm here today on behalf of PRACALT.org, a globally distributed nonprofit that uses a combination of digital strategy, service design, software development, research, and other forms of visual design to try and find ways that mobile technologies can be used to improve the lives of people living in poverty, of poor and vulnerable communities. Since being founded in South Africa in 2007, we've worked with NGOs, social enterprises, and governments to try and find ways that they can use mobile phones to deliver vital services and essential information. We work across a range of different areas, from government transparency and civic engagement, through to sexual health and youth workforce development, and projects which look at connecting adolescent girls, in this example, to female mentors as a way of trying to change gender norms in some of the countries in which we work. But enough backstory. Back to mothers in South Africa in 2014, we met with the National Department of Health in February to discover what they required for the creation of this national mobile registry. And we discovered 2 horrifying things. The first, in February 2014, when we met, they had the expectation of launching the service in 2 months' time, in time for the next general election. I know my fellow speaker here, Roseanne, is fond of saying that one of the ways that you can try and encourage creative solutions to emerge from your work is by setting yourself crazy, ambitious deadlines and targets. I will admit that we did have to come up with some creative solutions, but I wish that the deadline and targets hadn't been quite so crazy, because the government wanted to launch this service in 2 months' time nationally in every clinic in the country. The second scary, horrifying thing that we discovered during that meeting is that the National Department of Health was very much focused on the technology. And one of the ways that we had to be creative right from the start was in refocusing their attention not on the technology, but on the users of the technology. We managed to, again through fairly creative means, convince them that a 2-month deadline wasn't really realistic for the project, and instead managed to extend it out to 6 months. Still not very long, considering all that we had to accomplish. Through a series of workshops with various stakeholders and engagements with women, we managed to plot out the health journey that every woman in South Africa went on from the moment she discovered that she was pregnant to the delivery of her child and beyond. And through that mapping exercise, we developed a suite of mobile services that addressed a variety of her needs. These services, centered around a stage-based set of health messages delivered by text, were designed to be accessible on virtually any device, either for free or at a price point that was affordable for the woman that we were working with. One of the unexpected features that we added to the mix was a service rating, which I'm going to get into a little bit later. Intertwined with these services that targeted women themselves, we also created a variety of complementary services that were targeted at the health administrators, turning the data that we were collecting from women into insights, into actionable intelligence that the National Department of Health could then use to create better plans and to introduce new ways of managing the services that they were delivering to women. In the 2 years that Mom Connect has been live, we've sent over 50 million messages to new and expectant mothers at a cost of just under $2.50 per user. There are more than 1 million women who've signed up to Mom Connect since we launched. Of those million women, 450,000 have sent and received messages using a text-based automated help desk. 230,000 women have completed service ratings, rating the services that they receive at clinics and other health facilities according to a range of different metrics. Of the million, we've only had 90,000 opt-outs. And of the 90,000, most of those 90,000 have registered either a stillbirth or a miscarriage as the reason for opting out. 95% of the health facilities have signed up to the service. And thanks to our partnerships with academic institutions in South Africa, we know that the users of Mom Connect have significantly better levels of knowledge and perceptions of self-efficacy than women who have not signed up to the service. We're still trying to track what that means for health-seeking behaviors and for improved health outcomes, but so far the indications are very positive that this will have the impact we're looking for. I'd love to be able to say these numbers are the result of the systematic application of design thinking to this work. I'd love to be able to say that. Unfortunately, I don't think that's really the case. And that's because up until very recently, our organization could perhaps be described as being more preoccupied with design doing than design thinking, to use a phrase that I learned from my friend Robert Fabricant, who's here today. We didn't come from a background in social design or in human-centered design. Most of the people working on the project came from the commercial world. I myself have been working as a designer in a digital marketing agency, a sister company of ours. My colleague Debbie, who was the chief architect of this project, was an interactive artist. And she learned to her frustration that often people visiting her installations at galleries did not interact with the installations in any way close to what she was looking for. And I think so as a team, there were a number of different intuitive, implicit ways. We were using many of the processes and techniques of human-centered design to approach this project, but they weren't very explicit. Since then, the organization has changed quite dramatically, though, and we've begun to engage with all of the good work that's been done in this area and to try and parse out and tease out what we mean when we say design thinking or human-centered design or social design or co-design or social innovation. And I think it's important to reflect on or to share with you why we've made that dramatic change, considering that we seem to be going along fairly well as it was. The first reason is that the organization has grown quite dramatically since we were founded in 2007. Every year that we've existed, we've almost doubled in size. And as we've been bringing more people on board, we've needed to more carefully articulate, standardize, and concretize how we're doing what we're doing, so that new members of the team understand how to take on the work, make it their own, and extend on it as we try and replicate projects like Mom Connect in other countries. As we become more ambitious about the projects, we're also dealing with a much larger number of stakeholders from different backgrounds. And it's important for us to be able to speak with a shared vocabulary to these audiences, and important for us to be able to make a persuasive case for why we do the things that we do. Another very important reason for making this change is that the pages of peer-reviewed journals are filled with examples of mobile pilots, promising mobile pilots that never really went anywhere. At PRECALT.org, we believe that it's important to think more about systemic change than in demonstrating the use of a particular mobile tool or a particular technology. We've seen to our own expense how a very narrowly focused technological intervention can only address a small part of the problem, and even then doesn't always have a hope of making a significant change in a person's life if the enabling environment around them doesn't support the service that you're trying to provide through a technology. So in an attempt to be much more intentional about what we're doing, much more intentional about how we're trying to change systems, we've had to refocus the organization. And in the last 2 years since we've launched Mom Connect, we have a dedicated service design team. We've infused our entire organization with co-design and human-centered design methods and practices. Whereas engaging with users used to be an irregular, ad hoc activity, it's now become the core of what we do as an organization. And we've managed to apply this to the extension and replication of Mom Connect, our project in South Africa that delivers a variety of services to new and expectant mothers. We've managed to take Mom Connect and replicate it in Nigeria, where it's called Hello Mama, and in Uganda, where it's called Family Connect. And in each of these cases, although the core technologies and the core services have remained the same, how they're presented to users, what needs they're fulfilled, how they're actually articulated has been dramatically different in each case because of what we've learned by engaging with users and other stakeholders. In an ideal world, we'd be able to compare the health outcomes from these two other projects, which did use human-centered design in a much more intentional way, with Mom Connect, where it was much more intuitive and much more implicit. And we'd be able to say, oh yes, of course, look at the 10% increase in mothers going to seek antenatal care. Look at the number of mothers who are now delivering successfully in a facility. But unfortunately, the conditions in each of these countries are so different that it's not possible for us to make a fair comparison. So instead, we're reduced to using the same engagement metrics and the same indicators that we're using across all of our projects and just looking at these projects in isolation. And I just want to pause here quickly to reflect on one aspect of this project that we think of as very important, and that is really shaping how we think about the work that we do and is also related to our focus on users. For Mom Connect, our project in South Africa, we created a feature that allowed women to rate the services that they receive at clinics. This was one of the features which, unfortunately, we did not have a chance to test with users. It was not a feature that they asked for or that came out of any of the focus group work that we did. It came out of a suggestion from someone at the National Department of Health in South Africa. But it's become one of the most important critical components of this project because of the way that it gives our users a voice. The National Department of Health now meets weekly to review the service ratings that are being collected from users on a national, regional, and granular level to understand how the services that they're delivering to users are actually impacting their lives. But that still doesn't help us answer really what value design has brought to these projects, what impact the activities that we're using to create these services has brought, and how that's changed the health outcomes. But we have a few ideas of how we might do that. In South Africa, we've been talking to nurses and midwives to try and understand how we can improve the number of women who've been registering for Mom Connect. And because of that, we've launched a new suite of mobile services targeting nurses specifically. This is just launched last month, but our expectation is that we'll see increased numbers of women registering, increased engagement, and hopefully improved health outcomes as a result of this tweak to the existing program. A tweak that is the result almost entirely of the human-centered design practices that we've now introduced in a much more intentional way to our organization. And that should provide us, at least for this little tweak, with an understanding of the difference that design has made. Similarly, we're looking at differentiating or to create different packages of services, different mixes of content for different users. At the moment, most of our users receive the same set of messages with some personalization based on risk profile, but it's more or less the same. But what if, through human-centered design, we managed to identify more specific risk profiles that had specific needs attached to them, and then developed different mixes of the service, varying, for example, message frequency, timing, tone, content, and testing these using different cohorts of users, running A/B testing across our live platform to understand how we can optimize the messages, how we can optimize the service to give it the best possible chance of succeeding. And I think, to refer back to the slide where I talked about design doing versus design thinking, one of the reasons I think it's important to emphasize doing, not to necessarily position it overthinking, but to maintain some kind of tension between thinking and doing is, at least for our projects, so much of the learning has happened after launch. And most of the time when I speak to designers and they're talking about the work that they're doing to develop a service, it seems that their work is concentrated before the project even launches. And so looking at how we might measure the impact of social design, of human-centered design, of design thinking, running these tests on live projects, iterating on the live projects, to us seems to be one of the most promising ways that we might do that. Before I end, I just want to quickly talk about some of the other ways we might think about the value of design thinking, the value of human-centered design beyond health outcomes or beyond the quantitative measures that we might use. And for us, design thinking has been very important in transforming our organization, in giving members of our team who never go out into the field and who never meet users an opportunity to feel that they're closer to the work, much closer to impact. The software developers who are part of our team, who sit in offices and look at screens all day, thanks to the design thinking work that we've been doing, thanks to the human-centered design techniques we've been using to engage with users, feel much closer to users, and the team as a whole is much more dedicated and committed to the work than they ever have been before. And I think that alignment of mission is one of the important byproducts of human-centered design. Very importantly for us, there's an ethics that sits underneath human-centered design, which is incredibly important to me personally, but also to my colleagues. And I'm quite nervous about some of the ways that techniques we're using, the techniques we're developing, particularly around machine learning, behavioral economics, and nudge theory, can be instrumentalized for a variety of uses and ends which may not necessarily have the user's best interests at heart. And I think it's important to remember that there's an ethical dimension to human-centered design and to putting users at the center of our work, which is a justification on its own in some ways, outside of what it might mean for health outcomes. Finally, what's wrong with this picture? This is my colleague Debbie at a user acceptance testing session in Uganda at the end of last year. And while I'm very proud of the work that we've done to make our team as diverse as possible at PRECALT.org, too often we're in situations where we're inserting someone from a very different background with very different levels of education and experience into an environment where they're expected to extract insights from our users. And despite using every technique and tool at our disposal to try and minimize the power disparities between our designers and the people that they work with, I think we have a mission to think about how we make these engagements much more equitable and how we make them about the transfer of skills rather than just a means of designing better services on their own. Thank you very much.